Hello everyone, my name is Radwa. I did my week presentation on pulmonary embolism. So let's discuss the disease process for pulmonary embolism. Anatomically, the body's circulatory system is made up of the heart, arteries, capillaries, and veins. In a healthy individual, inside the heart, the blood is ejected with great force into the arteries. The blood flows from the arteries into the capillaries. The blood then circulates back to the heart through the veins with no disturbances. The factors of predisposing to pulmonary embolism as well as DVT are the same, and both medical conditions broadly fit the Verkes triad of venous stasis, injury to the vein wall, and enhanced coagulability of the blood. In an individual with any of these predisposing factors, as their blood moves back to the heart through the veins, the flow of the blood may be affected and become slower. The slow blood flow may become stagnant and lead to clot formation. Once a clot has been formed, part of it can potentially get dislodged and flows with the blood migrating to another area of the body. Often, one of the areas the clot can travel to is the lungs. When the clot or the embolus has reached the lungs, it is called pulmonary embolism, also known as PE. It is a life-threatening medical condition as the embolus suddenly blocks majority or all of the blood supply traveling to the lungs. In most cases, the blood clot which has caused PE begins forming in a deep vein located in the leg. Therefore, it travels to the lung. In other words, PE is preceded by deep vein thrombosis. The pathophysiology of PE. Blood clotting is a normal physiological process in the circulatory system to prevent bleeding. The body has all the needed components to make blood clots and then be able to break them down when necessary. However, under certain circumstances, the body may not be able to dissolve or break a clot down. Consequently, the failure to successfully break down a clot may lead to an erupting serious health concern, which is PE. PE is not an isolated condition of the chest, but rather a complication of venous thrombosis. The majority of PEs originate as a thrombi in the deep veins of the legs, most frequently in the calf veins, which is the most common site of thrombosis. The specific type of blood clot is called a deep vein thrombosis or DVT. The body's physiological as well as clinical consequences of the effects of PE vary from patients being asymptomatic to those presenting with hemodynamic collapse or sudden death. The clinical consequences of a dislodged embolus has a direct effect on the individuals depending on where it travels to within the systematic venous system, the duration over which the obstruction accumulates, the extent to which it obstructs the pulmonary circulation, and any pre-existing state of the patient that has been identified. Moreover, the effects of a pulmonary embolus depend largely on its size and therefore the location of the obstruction within the pulmonary circulation. Therefore, it is vastly important for providers to have a clear understanding of the pulmonary pathophysiology of PE, of the effects, the choices of interventions while treating certain risk stratifying patients. Interventions vary based on whether the treating provider chooses to treat with systemic thrombolytics, anticoagulations alone, or if invasive surgical treatment is necessary using mechanical thrombectomy. PE contributes to hypoxemia, as well as gas exchange abnormalities due to the lack of lung tissue receiving their needed nutrients and oxygen by the separate bronchial circulation. Small-sized emboli located in the pulmonary arteries are usually described as silent, or patients are said to be asymptomatic. However, the presence of multiple small-sized emboli is described as an emboli shower. A shower of emboli can often cause equal damage to that of a larger sized embolus. Respiratory impairment can occur when blood flow is blocked from reaching the larger arteries in the lungs by the moderate-sized emboli. As a compensatory mechanism, reflex vasoconstriction occurs, which then further increases the pressure that is already within the blood vessels. However, the hemodynamic consequences of PE are predominantly the cause of increased morbidity, and mortality. If the circulating emboli travels through the systemic venous system, obstructing the pulmonary circulation through the right-sided chambers of the heart, it will compromise the pulmonary arterial system. As a result, infarction occurs involving a segment of the affected lung and a pleural membrane within the specific area. Additionally, the cardiovascular system is substantially affected by the lack of blood due to the obstruction of large-sized emboli. Ultimately, this obstruction causes right-sided heart failure and decreased cardiac output. To explain further, due to the increased resistance within the pulmonary arteries, in addition to the reflex vasoconstriction, results in a decrease of systemic circulation. This leads to low cardiac output as the blood returning to the heart from the lungs is diminished. This often places an individual at a great risk of shock and sudden death. So, who is at risk for developing PE? There are inherited risk factors as well as acquired risk factors in developing a PE. An individual is more likely to get this condition if there is a family history of inherited blood clots or certain clotting formation or clotting disorders, such as antithrombin 3 deficiency. Women of various ages are at an increased risk of developing PE if they are taking birth control pills or on estrogen replacement therapy. Additionally, pregnancy, post-childbirth, or post-C-section will also place women at an increased risk of developing PE. Patients who are at risk for PE up to a year later post-surgical interventions to their brain, joint, or bone, especially after sustaining burns, severe injuries, or fractures to their thigh or hip bone. In certain situations, in which mobility is limited, such as paralysis, prolonged bed rest, flying or riding in any form of transportation for a long distance, will increase the chances of having a PE. Obesity, smoking, advanced age, and other medical conditions will also increase the chances of having PE, such as varicose veins, prior history of strokes, hypertension, COPD, cancer as well as cancer therapy, heart attacks, heart failure, or previous heart surgery. Any of these situations can make an individual more susceptible to developing PE. So, for the major signs and symptoms, PE has a broad spectrum of clinical pictures as the extent as well as its chronicity of the obstructions can vary so widely. The extent of the damage and its presenting symptoms depend on the patient's history of any pre-existing cardiopulmonary diseases, as well as the size and location of the blood clot. This is important as the symptoms of PE may mimic other medical conditions or problems, especially in patients who have an extensive prior medical history, making it difficult in certain situations to diagnose PE. Although the symptoms of PE may be quite nonspecific, each individual may present with a wide spectrum of symptoms. Many of the most common presentations of PE is apparent distress with a sudden onset of shortness of breath that is also rapid and shallow in quality. Some may experience symptoms that are accompanied by chest pain or pressure that worsens with deep breathing. Some of the chest pains is described as a sharp or stabbing pain under the breastbone on both or only one side of the chest. Patients may also present with a constant cough that is possibly accompanied by hemoptysis. Other signs and symptoms of PE might include anxiety, dizziness, lightheadedness, fainting, irregular heartbeat, tachycardia, palpitations, sweating, and hypotension. Furthermore, Patients also have additional symptoms of DVT, including redness or discoloration of skin, warmth, tenderness with touch, soreness, swelling, and pain in the affected leg. The pain increases especially when the patient is standing or walking. In general, people with pre-existing cardiopulmonary disease or who are advanced age, frail, and depleted will be much more sensitive to the effects of PE in comparison to others who were well and healthy until the embolistic event occurred. So how do we diagnose PE? It's often difficult to diagnose as its presenting symptoms may resemble many other conditions and diseases, such as aortic dissection or heart attack. Furthermore, patients with a DVT may be asymptomatic until a clot is dislodged. Therefore, the provider must have a high index of suspicion along with patient's detailed HMP in order to test for PE. Once the provider has access to patient's symptoms and performed a complete medical history and physical exam, the treating provider might also order several diagnostic tests. Pulse oximetry, as well as arterial blood gases, known as ABG, may be ordered to assess how well the lungs are working. Several non-invasive imaging tests can be conducted to help determine the location of the blood clots as well as assess any symptoms associated with it. A chest X-ray can aid in the determination of whether the presenting symptoms can be explained by any other conditions, such as with pneumonia, or whether there is fluids in the lungs. An EKG is also done in order to rule out a heart attack. A pulmonary ventilation perfusion scan, also known as VQ scan, is a nuclear radiology test that can aid in a diagnosis of PE, or it may help to rule it out. This is done with a small amount of radioactive substance that helps the examiner inspect the lungs. It evaluates one's ventilation, which is the movement of air, as well as their perfusion, which is the blood flow within the lungs. This test is normally recommended for pregnant patients or renal patients. In a pulmonary angiogram, a dye is injected into the artery, which helps the examiner evaluate and rule out other conditions such as aneurysm, stenosis, or the presence of any blockages. Another diagnostic test is CT scan, which is the main diagnosis test for PE. It is a three-dimensional exam that is done on the patient's chest as well as lungs to look for any presence of blood clots. MRIs are helpful as well as it depicts detailed images of one's organ and structures within the body. Additionally, duplex ultrasound are ordered as a diagnostic test for PE as it creates images and in return aids in the assessment of blood flow as well as the structure of the blood vessels in the legs. The treating provider will also order certain blood tests such as D-dimer, which helps assess the degree of patient blood clotting status. Other blood work may include testing for any other possible contributing genetic clotting disorders, such as antiphospholipid antibodies. Genetic testing is also done to look for any changes that will most likely place an individual at risk of developing blood clots, as in with lupus and protein C and protein S levels. Thank you so much for listening. I hope you learned so much from my presentation. Thank you so much.